Hello, everyone. Welcome back to Informed Dissent after a 2-week summer hiatus. This is a news podcast that brings you dispatches from the gender culture war. I am Ben Appel, the author of Cis White Gay, The Making of a Gender Heretic. I'm here with my co-host, singular, a gentleman of trans experience, Corey Cohn. And we have a special guest today, Dr. Lauren Schwartz. Sarah is and Lisa and Jamie are out for different reasons, so they'll be joining us again next week. Dr. Lauren Schwartz is a psychiatrist, and she's a senior fellow at Do No Harm, and she's also a co-author of a chapter in Lawrence Krauss's new book, The War on Science, which actually another one of our guests co-wrote a chapter in it. Alex Byrne, he co-wrote a chapter with Modi Gorn. I don't know if you saw his. Anyway, we can get into that maybe later. He had a great tweet response to a review that was written in New York Magazine this past week of Lawrence Krauss's book. Anyway, and then a lot of other contributors. I think Peter Boghossian, like 39 individuals contributed to that book. Scientists. There you go. Yep. And so that's out now. I think it just came out at the end of last month. So we're excited to have Dr. Schwartz here because also I actually became aware of Dr. Schwartz. Should I call you Lauren? Dr. Schwartz? I'll call you Dr. Schwartz. Yeah.
I respond to all of it.
No, I like Dr. Schwartz. I like that. So I became aware of Dr. Schwartz's work when a paper was published, like a review. What was the journal that it was published in?
Discover Mental Health.
Okay, Discover Mental Health, and it was about, I can read off the title here, Emerging and Accumulating Safety Signals for the Use of Estrogen Among Transgender Women. So it's, and what it is about, it's not necessarily measuring, it doesn't do anything like, measuring effects of estrogen use, but when it's like, you're talking about safety signals, you're saying in the medical literature, there's all these things that are coming up in studies regarding estrogen use in males. So it's like if they say like heart conditions it's like, oh, this seems to be popping up. We don't know what's causal. We don't know, what's just correlation, what's causal, what the confounding variables are. There's a dearth of systematic reviews, and we really need to do more. Am I summarizing that properly?
Yeah, absolutely. And it's how we approach everything in medicine. When we're looking for harm signals, this is kind of the way we do it. So we put it all together in a review that then was published in a peer-reviewed journal, which was helpful. So yeah, but absolutely, yeah,
Okay.
You're looking for harm signals across all different types of studies, whether it's a great study or not. You still are looking for harm signals.
Great. Well, we're going to get into that actually. And so, gosh, I'm like not doing a good job here because I had 2 weeks off. I'm going to do a couple headlines and then we're going to get into our discussion with that. But I do want to read these off because there's a couple developments this past week or two or whatever. The 8th U.S. Circuit Court of Appeals said Tuesday that a federal district court had erred in striking down Arkansas's bill that banned pediatric sex modification in 2023. So the 8th Circuit said that the former ruling had, now conflicts with the Supreme Court's Scarametti decision. So they're allowing that Arkansas ban to stand. The Air Force, this is big news and it really interesting. The Air Force has reversed its early retirement for some trans service members. I'm reporting from 9 News. This has been reported a lot in a lot of places, but transgender airmen with 18 to 20 years of service, this is how it was before, were allowed to take early retirement. So 18 to 20 years of service were allowed to take early retirement and receive the same benefits typically granted after 20 years for any airman, any Air Force member. In May, the Air Force briefly extended that option to those with 15 to 18 years of service, because as we know, transgender servicemen and women are being forced out of the military, and a little more than a dozen airmen were approved before the decision was reversed. So that decision was reversed, and it's left a lot of transgender service members and other branches worried about their own retirement options. So we're not sure how this is going to affect other branches, but it likely will. But it's just kind of odd that the Trump administration is going back and forth on that, and I don't like that. I know that there's probably a diversity of opinions about that from our listeners and maybe even on our panel right now. But anyway, that's not our discussion today, but that's a little nuts. And then the Education Department is investigating, the U.S. Education Department is investigating 4 Kansas school districts over their trans student policy. So like this investigations of school districts around the country continues. Their policies regarding this one is a student's parents, let's see, I'm sorry, policy that asks staff to not disclose or use caution in revealing to a student's parents when a student requests to use a different name or pronoun at school without the parent's permission. So that's in all 4 districts. So that's what they're looking into. And then in 3 of the districts, the policy, which is a common at a lot of schools around the country, they allow trans identifying students to use the restrooms and locker rooms that quote align with their gender identity. Anyway, there's a lot of other news headlines. As listeners know, for paying subscribers, I put together a weekly news roundup every week that comes out on Fridays at 4 p.m. So if you would like to receive that and get in on that, you can become a paid subscriber. And thank you to all of our existing paid subscribers and listeners. Okay, so back to...
Oh, could I just jump in, Ben?
Absolutely.
Because you put in so much hard work every week on the newsletter. You are often helping with the editing of these weekly videos, which is also shared by Lisa and Sarah. And I don't know if Jamie has done any of the video editing, but I'm sure she has. I haven't. I'm a lazy slob. However, what I would encourage for anybody who appreciates informed dissent, help us keep it going. If you are not a paid subscriber and you can easily afford it, would you please consider subscribing so that the team that puts this together is able to do so indefinitely? Thank you so much.
Thank you, Corey. I appreciate that. Okay. Yes. Wonderful. All right. So let's talk about, I want to start, Corey, you can jump in whenever. This is going to be an informal discussion. We'll just have a gab session about all this stuff. We all know about it. We're all schooled, but this is our first time meeting. So it's like a get to know you and let's talk about gender and let's talk about all this really interesting stuff, our own experiences, etc. The first thing I want to hear a little bit about, Dr. Schwartz, is your experience, kind of getting into this. Like what led you to Do No Harm? And what led you to contributing to this book. And also, I want to let readers know something I just learned before we started recording. Dr. Schwartz's chapter that she contributed to Lawrence Krauss's new book, The War on Science, she co-authored with her father, Arthur. So it says Lawrence Schwartz and Arthur Rousseau, and she just told me that Arthur Rousseau is actually her father. So he's also a psychiatrist, and she ended up going into his private practice. He retired 3 years ago, but they co-authored this chapter together, which is really cool. Anyway,
tell us about your father.
Not to take a completely analytic Freudian approach.
A Freudian approach. No, but how did you get into the gender thing? What led you here?
Gosh, and it's funny because I've answered this question recently, and I really came about it kind of in an unassuming, very organic way. I'm a mom of 3 also. So actually, I think what first put it on my radar was school stuff, and nothing egregious, nothing terrible, but several years ago, and this was probably, I know it was before COVID, probably 2018, 2019. We were just hearing little questions come home from our kids about stuff that just, as a psychiatrist and someone trained in mental health, developmentally were not appropriate discussions. And so I just was reaching out as a mom, just saying, hey, this seems kind of different. And for a little bit, it was, well, not a whole lot's going on. We're just testing these little things. Well, it turns out it was a little more than, here and there. There was several programs they were running at the time, and our kids kept coming home in carpool and asking us just questions they'd never asked before. and especially when my youngest was asking questions that were far different than what we were hearing, about math or science or English from our older kiddos. So, so then I did set up a few meetings with the school and just to ask questions, again, just as a parent, to say what exactly is going on. And they said, well, we're gonna defer to the experts here and just kind of shut things down. And I thought, well, I am a psychiatrist. Mental health and developmental psychology is a huge part of my education and background and what I use every day, but okay. So then that's where I went. I tried to start looking for the quote unquote experts that were showing up in our kids' schools and other kids' schools, right? This was kind of, you were hearing little things. And I feel like I was a little bit behind on some of it, but.
And this is in Oklahoma, right?
Uh-huh.
Okay.
Yeah.
And kids, I'm sorry, kids' ages, this is elementary, middle, what are they?
Yeah, I want to say my youngest was probably second or third grade at the time.
Okay. And your oldest was how old? Like
so
around?
he is 4 years older. So
Oh, okay, got it. So
yeah,
it was
so
mostly
kind of
elementary.
the elementary, yeah.
Got
Yeah,
it.
and again, there wasn't some big announcement that there was just, I really do think their school's probably doing what a lot of them were doing, just trying to do the best they could with information they were just getting dumped on them, and this is how you shouldn't handle it. And they were being asked, I think a lot of times, teachers and administrators to be psychologists in the room, which is completely inappropriate, and that's a whole different discussion. But I think, all that said, I just thought, well, I'm going to start doing research. That's what I do. I mean, I want to know anything and everything I can find. So when they were saying, well, we're talking to the experts and you're not one of them, I said, okay, I feel like as a parent, I'm an expert in my own kids. But all right. So I went and looked, and very quickly, you just start scratching the surface. And even my own professional association, the American Psychiatric Association, it was just, I had no idea how much they were platforming and they were promoting this and they were behind it fully. American Medical Association, American Academy of Pediatrics, just all the associations that I lean on for guidelines, for resources. Everything that they do is, at least it's told to us and sold to us as the highest level of peer review. The only thing that we're publishing is the most scrutinized, most rigorously developed things. And as a clinician, day in and day out, where I don't have time to run my own experiments, nor would I want to. I'm not a researcher. I'm working with patients every day. I rely on those heavily. You have to. So then as I'm digging into this and I'm trying to figure out, I'm seeing GLSEN, and I'm seeing, the American, I can't remember if it was the Society of, or, school psychologists, and their pages were covered up with resources, but resources that weren't rooted in anything. There was no science behind it. This was all under the umbrella of, supporting and caring for kids and socially and emotionally supporting them. And so very quickly my school said, well, apparently you don't support emotional learning or social learning, or, what, are you anti, suicide education too? And I thought, oh, wow. Okay. This is a very protected, I don't even know what to call it, process or, set of information. So that's about that time I found, I was actually a fellow with Fair in Medicine for a couple of years. And at the time, I mean, it was right in the very beginnings. There were just a handful of us as physicians. So then I really started learning about, all the things people were coming across, and it was pretty grassroots at that point. And then as soon as Do No Harm launched, it came across my radar just in an email. I was like, well, this is interesting. And it was, I mean, they've been just such a huge, I think, resource for me, just in getting to know people and talking with people across the country about just different things going on, whether it's DEI or gender related stuff. But then I very quickly, I think it was maybe it would have been 2022, I was introduced to Miriam Grossman. So she is just an incredible, I would call her a mentor and inspiration, but also I'm, very thankful to be able to call her a friend. And she and I talk frequently. I'm working on a project for her right now. I mean, she's, when I started talking with her about it, I thought, oh my gosh, I'm so far behind. I mean, she's been doing this for decades. And every time I'd say, oh, did you know they're doing this? She'd say, oh, honey, that's been going on for years. So it was a very...
So Dr. Miriam Grossman, she's is she a psychiatrist or...
a child and adolescent psychiatrist, yes.
Psychiatrist. And what's her book called? It came out like 2 years ago.
Yes, Lost in Transnation.
That's what it is, right.
Yep, and I helped her with several of the chapters, just in terms of doing research for her. I mean, she obviously wrote the whole book. And then I had the honor of getting to write 2 of the appendix sections.
Oh, great.
And so that was really kind of where I started working with her. And she's also at Do No Harm. And so there's just been overlap there. And then other doctors I've been able to get in contact with and write things with, Miriam, and then Carrie Mendoza and Aida Sarandolo. The 4 of us wrote an open letter to the American Psychiatric Association when their gender affirming psychiatric care textbook, by the way, platformed by their own publishing house, was released in November of 2023. We sent them the letter. We, just said, how can you call? I mean, it was outdated before it was published. It says puberty blockers are fully reversible. Cross-sex hormones are in the transgender community, relatively safe, effective. We can't comment on any of, the harm signals because we just don't have enough data, which is ridiculous. And so we just try, and their whole surgery section is basically a chapter on how psychiatrists can write letters and get out of the way.
This is you said the gender affirming psychiatric care, the textbook by the APA. Is that what you said? So the American Psychiatric Association. Okay.
Yeah.
Because you mentioned that you cite that in your chapter that you co-authored, and that actually really jumped out at me. And I'm glad you brought that up because, you were just mentioning about schools, like all of these so-called experts that come into the schools, and, they're just entrusting all of this to them. And that, I think, is the crux of the problem. Leo Sapir has talked about that too. Like the hurdle or the whatever it is, the roadblock is like all of these special interest groups, really running the show here. But I wanted to say just a couple quotes because this really jumped out at me when I was reading this chapter. It says you write in the chapter. The current academic state of affairs is a direct result of the infiltration of social justice into medical education, which we're aware. We can all agree. Like, yes, we're aware of that. And you say this pernicious influence appears in the APA's textbook, which you just mentioned, which instructs trainees and practitioners to ignore evidence-based practices. And then you quote it, and it says, TNG, which is, I guess, they transgender, non-binary, gender non-conforming, or gender diverse,
Correct.
which is crazy. Anyway, TNG patients, this is a quote from the textbook, the gender affirming psychiatric care textbook from the APA, which was published in 2023, you said?
November of 2023. Now remember, and this is the same publishing house that publishes the DSM.
Okay,
like our diagnostic, yeah.
I mean, that's just insane. Not even 2 years ago. Okay. TNG patients may not desire what the medical industrial complex considers evidence-based. In listening to our stakeholders, we needed to stray outside of evidence-based cognitive behavioral therapy or dialectical behavioral therapy groups and provide non-clinical groups, imagining non-traditional mental health services to foster empowerment, resilience, and gender euphoria, end quote. And then you continue.
That sounds great.
Right?
Yeah.
The concluding chapter from the book, which boasts, quote, evidence-informed, end quote, versus evidence-based methods. So evidence-informed, it's saying, which should be evidence-informed. Quote from the book, cisgender people in power have traditionally created systems that bar access to quality gender-affirming care. Instead, TNG communities should lead the way, reimagining the bounds of healthcare and fostering an activist healthcare environment that provides comprehensive care. We need systems that are dedicated to advancing gender-affirming care. We have a duty to fight injustice in every encounter to ensure people are affirmed. The right care does not just mean treatment or prevention. It also means affirmation. This is from the same publisher as the DSM. Corey, what do you have to say about that? I'm sorry.
It sounds wonderful. So we're looking at this with hindsight. And I think that's important to remember. For many years, there are people who expressed all sorts of bad feelings. I'm trying to figure out a different word than dysphoria, but dissatisfaction with living in their assigned sex role. Let's say it that way. They felt terrible being men, felt terrible being women, and here was a medical pathway to help them move into a different role. And on the surface, it appears to work. And people who have done it, who've gone through it, there's no shortage of people willing to give testimonials about how much it's improved their life. So when you look at this retrospectively, it's like, yeah, there was no evidence. Why were they doing it? But when you had a zero evidence base back in the 1980s, back in the 1990s, and all you had was a collection of anecdotal information, if you really cared about helping people who were suffering, it's very easy to understand how you could get recruited to support this type of therapy. I hate to even use the word therapy, this process, right?
Yeah.
So it's easy to understand in light of no evidence why you would come on and support it. I say that having gone through it. And it's also easy to understand that as evidence starts to become more available that discredits these processes, why it would be difficult to change your mind because you've already become so committed to it.
Yeah. Oh, and I think to add to that, I think this was such a different approach to medicine. I mean, it's not medicine. It's empty promises, and it's misleading patients in a very, in my opinion, in all kind and harmful, unethical, or even counter-ethical. I don't even think I think it's beyond unethical. But I think to your point, the promise of this is going to solve this distress I feel. And in our chapter, that's the first thing we say is no one is denying that distress is there and can be horrific for patients. And it's just, why are we providing this, cohort of patients substandard care when we would never do this in any other patient population? And the idea that somehow we just ignore evidence. We go ahead and give the most invasive, most destructive, permanently damaging treatments to otherwise healthy bodies, with no data to really show any benefit, but definitely we're seeing a lot of harms, and harms we knew. To me, there's no mystery out there that supraphysiologic or very, very high doses above natural levels in a human being, if you give super physiologic doses of estrogen or testosterone to the opposite sex, there's going to be damage done. That's endocrinology's known that forever.
Yes, the patients know that.
Yes, absolutely. But in my long rambling talk, part of I think what I was going to get back to, and that reminds me of it, is that in this particular patient group, patients were so scared, and still are, I think, to come to their physicians and say anything about side effects because they've been told if you don't stay on this path, you're going to kill yourself. So any side effects that you report, we're going to have to take you off that medicine. So I guess you're just doing trans wrong also. And so now, and to me, it paints young children and adolescents and young adults into corners that are devastatingly hopeless, because they can't even go to the expert that's prescribing this stuff and say anything. And then if they do, most of the time, these gender affirming experts are doubling down on the treatment. They're going to just give them more. They're not going to treat the underlying issues that maybe the dysphoria or distress or feelings of incongruence are stemming from. So it just is one of the most heartbreaking things that I have ever seen in medicine. And I really am so disappointed and saddened by my profession because we've really let a whole lot of patients and parents and families down. They deserve so much better than that.
I have to imagine that one of the hardest, or maybe the hardest problem to address when you're making the sorts of arguments that you are, is now with a program like Informed Dissent, we're obviously dissenters, right? Not assenters. But if you were to accept an invitation onto a show that had somebody who was like happily transitioned, what they would say to you over and over is, me and my friends know the risks and our lives are better than they've ever been. Our health is worse in some aspects. We knew that going into it. I have higher blood pressure. I've got diabetes, whatever it is. But I can manage all of that separately. There's all sorts of treatments that I can take. There's additional medications that I can take to treat those types of effects. I am realizing a benefit from this. So encountering that viewpoint must that's got to be one of the harder things to hit.
And I think it's probably one of the things we're going to face as we move forward, because certainly there are medicines. I was trying to think of a good example for stimulants, for example, for ADHD. Well, if you take 4 times the max daily dosing of a stimulant, you might feel euphoric. I don't know about gender euphoric, but you might feel euphoric in general. It's like, well, that's fine. This is great. This is better than I've ever felt. Well, yeah, but your blood pressure is 210 over 110, and you are very underweight. So you're not eating at all. You're not sleeping at all. Eventually, a person that's not sleeping with really disrupted sleep is going to get psychotic. So whether or not a patient comes in and says, I'm euphoric and I am just so happy on this medicine, now it's devastating everything health-wise, it's my job, it's my duty, it is my obligation to say to that patient, this is killing you. This is physically destroying your body. This is not a healthy dose. Now we're also dealing with the difference there is FDA approved doses, which some people can't even tolerate just the FDA approved max daily dosing. In the gender affirming care world, these are all off label and used at completely different doses we've never put anyone on ever. 10 times as much, as let's say, a natal male has experienced or could experience ever in their whole life naturally. You're just flooding their system with a hormone. So it's yes, sometimes patients, and I would definitely say temporarily, feel better. So I think depending on how long a person has been on cross-sex hormones and how long, now there's not a choice for surgery. Now it's more of a have to, because either, let's say they're a female on testosterone and they have so much chronic pain and devastating atrophy that they have to have a hysterectomy, this is such a medicalized path that eventually there's a wall somewhere and we're creating that wall and patients are not informed of that.
Mm-hmm. What are some of the, not the most worst effects necessarily, but what are some of the most common effects? So of things that are bad, but are also commonly experienced by patients. What are some of those things?
With estrogen and males?
Yeah, let's focus on estrogen.
Well, we know there's
none of the girls showed up today, so we don't have to talk about any of that stuff.
Here's the thing. Estrogen, yes, it's new in this use, but we've been using it for a long period of time. And ask anyone who's ever been put on just birth control at kind of natural doses or hormone replacement therapy in perimenopause or postmenopause. It's not without side effects. So certainly now when you're escalating the amount to just a giant amount of, or I guess, supraphysiologic or unnatural levels of estrogen. Cardiovascular concerns, you've got risk of, we call it like venous thromboembolism, which is, blood clots that can form. Those chances increase over time, and I've got to be able to talk about side effects with patients, right? So if like all of a sudden you're having pain in your leg and there's redness and swelling and you're thinking, oh, it's just like, probably I just pulled a muscle, and you ignore it, it could kill you, and does kill people. There's, from reproductive harm, I think there's constantly the talk of, well, preserving fertility, and a lot of these folks won't have a chance to do that because it can be, high doses of estrogen can be very damaging to sperm production. Mm-hmm. Cancer risks, all kinds of cancers that the incidence is one thing, but it's also cancers that we don't necessarily see frequently in this particular patient population. So it's all of a sudden we're creating these new, very concerning cancer signals. Neurologic impacts, again, our review, we didn't do any new research. These are over 50 studies that we put together that already existed. They were all in peer-reviewed journals. So just to be clear, anyone practicing gender-affirming care in this manner and prescribing cross-sex hormones, these were available the entire time. So It's not like they were a mystery. We just put them in one place so that they can, not just, practitioners, but also, even if a parent or a a patient wanted to go look, we put it in a very clear chart. You can see some of just the concerns. Maybe it was in a case study. Maybe it was in a small number of folks. Maybe it was after a very long period of time that the original studies didn't, they weren't able to follow patients that long, but we get, some reports. None of those would be considered that gold standard top level of studies. You don't ignore it though. You have to at least talk with patients about, hey, we're not sure exactly how causal, that connection is, but please understand patients on this in other situations or patients that have been on this, for this amount of time, these are possible side effects. So metabolic, autoimmune stuff popped up, just increased weight gain, insulin resistance. We saw, some of them flagged for like lupus or rheumatoid arthritis. Again, it just very concerning, lifelong damage.
Well, I think one of the things that makes research around this so difficult, I don't know if you know this about the trans culture, but there are people who believe that your gender identity is determined by the hormones that you take.
Huh.
I know this is really crazy, and I'm simplifying it because I think even people who I would assign that belief would not want to accept it in those terms. Mm-hmm. But they would also say, if you don't let me take estrogen, then that's detransitioning me, which mm-hmm. is sort of bizarre in a way, because if you really believe, anyway. Accordingly, especially young people who really treat their bodies like they're race cars. Actually, I shouldn't say that because race cars are high performance. At any rate, they will take more testosterone to feel more masculine, or they'll take more estrogen to feel more feminine as a way of validating their gender identities. Yeah. So the degree to which they medicalize, even under the supervision of a doctor, is not consistent. And it's informed by incorrect beliefs about how what hormones do to your body.
Well, and what I think when you were saying that, also what came to my mind is, if you were, someone were to walk into my office and I'm peddling this pseudo medicine, and I'm saying, okay, yeah, it's just what hormone you put in your body that determines your gender identity. One, I think most adults would probably just look at me like, I'm crazy. Where did you go to medical school? And you probably shouldn't have a license. The people that I think the individuals that do believe it are kids. A child would believe that, right? That magical thing of, well,
they're adults also.
Yeah, and I think part of that is the solution or the hope of the solution locked in at a very young age. They were promised it, even if it was not by a doctor or in a doctor's office, maybe it was a promise that they felt like they heard on TikTok or their friends reaffirmed it. Oh, get on tea and it's going to make you more masculine, or get on estrogen. Mm-hmm. You're going to feel so much like a woman. I've had families tell me that their kids pushed back, and these aren't my patients, these are like just in groups where I've had, conversations, that their kids were saying, well, these aren't side effects. I just have to get used to this because this is my true self. And my true self has insomnia, and my true self gained 100 pounds, and my true self has cardiovascular dysfunction, and I've got to probably eventually get on insulin. It's that magical belief system that was so oversimplified that a child could buy into, that carries over. And it's, I can't imagine, again, facing just that idea of, oh my gosh, I have to let go of the hope that what they promised me, it doesn't exist. It's not real. And so then that's where and we see this not just in gender medicine, but in anything, it's like people can ignore that they've got very, very significant cancer for a long period of time before they go in to see their primary care. And it's like, how are you living like this? But they're a lot of times, I think that's just natural human cognition and our just the way that our, just observing self exists. We don't want to let go of hope that, no, they told me this is the solution. This is going to be the solution.
one of the points, I don't want to lose it too much, though, is that anybody who's studying the side effects of any of these interventions, that's the word, intervention.
Yes. Yeah. Not these are not treatments. These are interventions that are
These interventions.
Absolutely.
Anyone who's trying to study the effects of these interventions is going to have a very difficult time calibrating, because it's probably not the case that if you have a large enough sample size, that all of the patients, again, we need a whole set of language, because they're not patients, are they? All of the people being studied are following different protocols.
Mm-hmm.
So if you have 50 males, transgender women, under your study, some of them might be taking 1 milligram a day, some of them might be taking 6 milligrams a day.
Mm-hmm.
And if that's not a factor in your analysis, you don't really know what's coming out the other side.
Mm.
Well, and that's how medicine operates, right? Like we have to document all of those in experiment. That's why this is not medicine. This is terrible research. It's not even research. Right. It's just self-report stuff thrown together over time, which we know has all kinds of reasons that we cannot ever use that as the standalone research. Satisfaction and regret can't be our two measurements. But I think beyond that, it's just, we also know that even in the best laid plans for a research project that's been approved, right? Where this would never get approved in the first place. However, if it did,
right,
right, because it doesn't even meet minimum standards. But we know that happens. We know that something feels so bad, but a patient doesn't want to say, okay, this thing that I'm supposed to be taking, it just feels so bad, I can't, they may not report it that way. We know that what a patient's reporting is very different than what's happening, and for all kinds of reasons. It can be, but I think the other thing that doesn't get talked about very much is in psychiatry, especially if someone came in, for example, and said, I am severely depressed, I'm bordering on like just passive suicidality, I'm not going to do anything, but my gosh, I please help me, and we've done psychotherapy and we're working through this and we're trying to figure out, and we decided, hey, let's try a medicine. And then I walk through risks and benefits. And I'm sorry, if there's any medicine that you're going to provide a patient, you better be talking about risks and benefits. That is required by law and by ethics. But I think additionally, let's say they start the medicine and they have horrible side effects. Well, it doesn't mean they're not depressed. Just because they have a bad reaction, which some people have bad reactions to some medicines and they don't react to others. Sometimes they don't have a response that helps them. It doesn't mean they're doing depression wrong. It means that, okay, we need to find a different path for you that's better. And I think that's good. Excuse me, that's going to be our solution to this a path out of it is we have to do better. And it can't be, well, we kind of liked these things over here because they seem to sort of partially satisfy things. Yes, devastating and detrimental to overall physiology, but that's okay. We can't keep going in that direction. We have to find better options. And right now we're so locked into this harmful, devastating path. It's going to be difficult. It's going to be, but I'm not going to give up. I mean, this is just.
Well, in those quotes that I read before from the APA's textbook, when it talks about this like kind of social justice-y approach, like this is a very much like the Andrea Long Chu approach that we've talked about on this podcast before. Like your kind of own gender design, your body as a canvas. Andrea Long Chu even wrote in that New York cover story about how, trans kids should be able to change sex, quote unquote, that they should be able to do this. And it doesn't matter what the reason is, that there can be different reasons for deciding to alter their bodies, in this way. And it doesn't matter and it shouldn't matter. However they want to do this, that they should be given the freedom to do this. The freedom to change sex, I think, was maybe the title of the article. Anyway, this is that approach, and it's so deeply embedded. And I think I would venture to say that there's so many complexities about this, because we can't say that every patient that comes in is seeking it for this reason, or because they're motivated by this, or because they're drawn into the, gender cult in this way, or they're like, or they're maybe they're experiencing genuine distress, or there's just so many different routes. But when the overarching approach that's, in medicine, in these institutions, this cancer that's infiltrated these institutions, that's the only way I can describe it, that's metastasized there, when that umbrella is from this place of you get what you want, and this is liberation, like this is what freedom is, this is what your human right is to get and to be able to consume and to be able to be given what you desire, or what other people tell you you should desire or might want to desire, however you're gathering in that information, whether it's through your TikTok screen or through a television show, or because you went to a thing at your school and there are experts there talking about how euphoric they are. Whatever that is, you should be able to do that.
Yeah. Yeah. We call it, I call it vending machine medicine.
Right.
Right. Like that. And that's not medicine. And in no other, not to my awareness, at least, in no other area does anyone, I don't care if you're an adult or a child, no one has a right to bad medicine. Someone like a patient can't walk into my office and say, and demand, you need to give me 3 times the recommended daily value of a stimulant, or I want to take 10 Prozac a day at the highest dose, the highest capsule dose. Oh, no, because that's going to harm you. And I have to hold reality in the room.
Well, and also, go ahead, Corey.
Aren't there people who walk in and say, I want painkillers, or people who walk in and say, I want what are they called?
Like antidepressants or anti-anxiety or benzodiazepines like Xanax or Valium or,
No, the
antipsychotics?
No, the treat when you have a bacterial infection, but
antibiotics. Sorry.
Antibiotics. Thank you.
There we go.
Yeah, it's too much destruction of my gray matter here.
But ask any pediatrician. Oh, I'm sorry. Go ahead.
But people do come in and demand those things, or they come in and they say, I want the weight loss medicine, or they come in and say, there's this other thing that I saw on TV that I want. Don't they do that?
All the time, every day.
Yeah.
And it's not because they're trying to manipulate or do anything nefarious or try to harm themselves. They truly believe that after what they saw on TV, like there was I can't remember the commercial, but it had this really pretty butterfly. I got so many questions about, can I have the butterfly medicine? I'm like, do you know what it does? So
makes me a butterfly.
Right. Or antibiotics when you have COVID, because, it's not a bacteria. And ask any pediatrician how many times a day they have to tell parents, this is not a bacterial infection. We don't give antibiotics for viral infections. They're going to be just fine. It actually would do harm if we did. There's all kinds of side effects. You, as a physician, you don't go into medicine if you can't tell a patient no.
But they do. But they do say yes. There's so many doctors who say yes. And they're what's more is their incentive is to say yes, especially with the antibiotics, because here you can, if you absolutely insist that you have this thing, I'll give you a low dose of it because I know it's going to create a placebo effect.
But
and
here's the flip
if
side
I
of that.
don't,
Okay, what if I did that? Yeah, but what if I did that? Like, so what if let's just walk through that process. A parent walks in, their little kid says, I know this is an ear infection. Prescribe antibiotics right now. Don't look in their ears. I already saw on TikTok how to test for this. Give me the antibiotic. And I do at a low dose. And I don't treat kiddos with antibiotics. Anyway, and then that kid has an anaphylactic reaction to it. Guess who's responsible?
The manufacturer.
The doctor.
The prescriber.
Yeah.
So if you practice bad medicine and there is a bad outcome, that's on you. And that's where I think,
Well, and that highlights why, in Missouri, after these, like at Wash U, I think it was, when after this shut down and they were allowed, there was a grandfather clause, they were allowed to continue to, and they shut the entire thing down because you can speculate that they knew that kids were being harmed and that they didn't want to be on the hook legally in the long run. This idea of extending statute of limitations for people being able to sue for it's scaring these medical providers because they know that there are, and they see that there are adverse outcomes, or not only that do they see them, but they just don't even know. They're like, actually, yeah, this is completely unknown. I'm going to send you down this path. I don't know what's going to happen to you in 6 months, let alone 6 years, let alone 16 years.
Right.
So it's really, and that's what really gets under my is the gall of these authors in like this textbook that you quoted here
Hmm.
to refer to the denial of being able to get uh, uh, medicine on demand, whatever you desire, and to kind of like go against evidence-based medicine as the medical industrial complex. Like that's to
Like we're the
me,
evil. Yeah.
what is a better description of a medical industrial complex than advertising that there's a problem that can be satisfied through overdosing on opposite sex hormones and denying your own body, let's say a male body, the natural hormone of testosterone, and then cutting off by whatever it is, and then creating these lifelong medical patients that are forever chained to the medical industry. What is, to me, if you say medical industrial complex, that's what I picture. I mean, that's dystopian.
Yeah, I have grappled with this, I think, since I became aware of it. I truly cannot in my mind understand how anyone, it's not like we spend like 3 or 4 weeks in med school. I mean, we're in medical school for 4 full years working through and studying all systems. And then we do our specialty might be, 3 to 7 years of specialty training. In psychiatry, I did 4. So and a lot of my rotations, even in my residency, were endocrinology rotations because there's such an overlap of mental health signals and endocrine challenges that kind of mirror each other. So you always have to be asking if someone's depressed. I got to make sure I run out the whole thyroid panel. We're looking for things all the time psychiatry specifically is really, our diagnoses are a lot of times diagnoses of exclusion. I can't go test for a dysphoria. I can't pull a lab of, well, how's your depression today? Oh, it's in the low or normal range, right? But we talk through things and rule out the medical issues. And in this case, that's the thing. Everyone that has gone through medical school, they had a lot of endocrinology. So when I saw the amount of testosterone or estrogen being prescribed young, healthy bodies, I just thought, because here's the other thing, I think we talked about it being off label, right? So, but off label for physicians, you have a much higher threshold of justifying utilization. So the lower, if it's a very, very low risk, really good chance of benefit, and it hasn't been FDA approved because I don't know, pharma wasn't going to make money off of it. Who knows why? Those we can justify a little bit better, right? Because, okay, there's no harm. You may not get benefit, but you might get some, and then we don't have to go for more risky things. In this case, there's very little benefit that you wouldn't get otherwise from something else. And maybe you could even have better benefit in therapy and if we're dealing with distress for different reasons, treating it with other things, preserve your fertility, preserve your physiologic functioning and hormonal functioning throughout your whole life. I don't understand how anyone is walking into a room and justifying this. And that is legally, ethically, and medically required especially if you're using something off label.
Mhm.
So I can tell I can get really frustrated with my own medical community for doing this to people. And taking advantage of them in a time when they are in crisis, especially in psychiatry. If you're in crisis, if you're a danger to self, if you're suicidal, or you're not able to care for yourself, everything else comes to a full stop. You don't provide invasive interventions at that time, ever. So,
Hmm.
anyway.
Well, I have a couple questions for both of you. One is, do you think that because we're talking about, overprescription of, let's say, estrogen in males, right? And the safety signals there and the possible repercussions, but also there's the denial of the natural hormone. So if what's more damaging? What's more destructive, or which is worse?
I mean, that's a I'm sure that's an individual question. And I think the other piece is I would lean on the answer that, hey, we don't know because we don't have long-term studies. That's probably a really important part to bring in with your patients. Hey, by the way, we don't know what's worse.
Right.
These both are going to be occurring because at some point over a longer period of time on high doses of estrogen, eventually you may have to remove healthy body parts that now aren't healthy.
Mm.
And now you can't produce your own testosterone and you can't rely on estrogen because you feel terrible on it. So now you're dependent for life on the non-cross sex hormone. I mean, it is so medically irresponsible and unethical.
And you might have heard, if you listened to our last episode, we were talking about Avery Jackson, the kind of like former poster child that was on the cover of National Geographic years ago about like the gender revolution. And we were talking about how, Debbie Jackson, his mother, is a male, identifying as a girl. His mother, when he was 11, put on puberty blockers and then cross-sex hormones right thereafter. And there's quotes from this parents Facebook group of someone saying like, "Oh, are kids depressed after puberty blockers? Did anybody run into this?" And Debbie Jackson says, "Oh, for a year, like it was within weeks after this puberty blocker was implanted, she, that's what they're calling him, really like just had a horrible crash." Horrible depression. We dealt with it for a year. It was scary. We ended up seeking SSRIs.
Oh my gosh. Okay,
And
great.
that's a quote directly from the mother of this
Oh,
child. So, I mean, that's nuts. I mean, we talk about the possibility of Munchausen's we talk about that, and who knows what that effect can have. But it kind of does relate to my second question, which is I suspect that because again, like I said earlier, there are so many different reasons and pathways why people might come to this. However they might be influenced to think that this might be a solution for them, especially young people, right?
yeah.
It can be in their peer group. It can be through a very, uh, an adult who has a great effect on them. But what is it also about the kind of allure of being unwell? Because for the past number of years, with this social justice approach in medicine, into everything, where the more marginalized or more harms you have, more trials and tribulations you're going through, more suffering you experience, actually makes you more of an exceptional human being or a more even moral or good human being because you almost like you kind of are closer to like the truth with a capital T because you are lower on the totem pole and therefore because you have your struggle with all of these things and therefore like you are more good, the more privileged you are, the more well, the more healthy, the more able-bodied, the more cis you are, the more whatever normal, quote unquote, you are, according to what all the people in power, say is normal, then you are corrupt.
Yeah.
You are, uh, 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 you know, just completely made up and modified and informed and formed by the system.
Hmm.
And so folks that are disabled, that are queer, because disability is anybody that's queer and that stands outside of that is somehow better. I wonder how many are, kids put disabilities in their profiles, in their social media profiles. Oh, I mean, I see this consistently, and I think that there is this allure there. I just think that that is a thing. And for people that don't know that or think that that's crazy, that is an actual thing. And I think that's just that this is such a bigger problem than what most people know it to be, except for people who are in the weeds of it like us. Like we know how big this is, that younger generations are being in some way led to believe, not all of the younger generation, not even all of the people that seek them, but a portion of them are being led to believe that there's something desirable or something more worthwhile about a life of being vulnerable, being victimized, being unwell, being disabled, and having multiple issues that require some kind of medical and psychiatric intervention. I go to Fire Island 5 times a year, gay, whatever, utopia in Long Island. And I'm coming home, and I see more trans. I come home. We're coming home on the ferry 2 days ago, and we get on, and there's a young woman in a wheelchair who has beard, facial hair. So clearly, this was a young woman. She still had breasts, who was on testosterone, and then wheeling around in a wheelchair. But my friend said to me, "That's interesting because I saw her walking down the boardwalk earlier." So it's like whatever this person's need for a wheelchair is, here's this person who is on testosterone, a young woman, and then she's in a wheelchair part-time. It was like, yes, you can spot that is kind of the picture, the definition, of the image of what I've come to think about, or starting to think about when it comes to medicalized trans identifying or non-binary identifying individuals, especially young people. Is that crazy? Am I crazy?
No, I don't think so at all. And I think, my first thought was, well, did testosterone do that to her? Is there a reason why maybe after a little bit on her feet, her joints have been affected, her bones have been affected, absorption of calcium. So that was kind of my first medical thought on it. But then also, I think to your point, I think this is such a huge thing that we've seen, especially with social media. We didn't grow up on, or I'm way older than you guys, so I didn't grow up on social media from the get-go, right?
I don't think you're way older than us. Yeah.
But these kids from birth, it's been available, and there's so much weight that they place on likes and how many views, and so then they compare themselves. So it's all this comparison. I know the word contagion's overused, but then it becomes this piece. People identify then with what they see themselves as a victim of, and think about what that does to just mental health in general. If your identity is fully wrapped up in whatever it is you struggle with, how do we help you out of that struggle? You're going to hold on to it so tightly for fear of losing self in the process of maybe setting that down and being okay with, okay, how do I learn to live with the things I'm not happy with, or that feel like they are absolutely wrong. But to say to a child, oh, you feel like you're born wrong, that's absolutely right. You were wrong. You were created wrong. You were made wrong. Your body's wrong. How do you start with that?
Mm-hmm.
I don't. Would you ever say that to a child that has cancer? Like, well, your body's just wrong. Well, no, oncologists don't take that approach. So how do we? I don't know how you line those things up with health and wellness, but I don't think you're crazy. I think the other side of it is all these kids are told, even by things they're filling out for colleges or whatever, they're asked, what is your gender identity?
Mm-hmm.
And what, how do you identify? I can't remember there were some medical school application questions that I was recently sent from the American College of Medicine. Anyway, it was just bizarre drop downs of all of these things that none of them were speaking to, a young person's strengths, or nor did it ask for that. How did you deal with this? Or it wasn't, because it was perceived as the thing. And then when kids are filling them out and they're like, oh, I don't have any of these. I must really be a bad person. It's like, what?
And that's become a joke. Like, oh my gosh, like you see it even parodied in like, sometimes television shows, like dark comedies, ones that are willing to take risks, where it's like, oh my gosh, I don't have any of these things. I'm so like, I'm not special in this way. But that's based on real, and that's why this pushback against DEI is so legitimate and so necessary. Maybe the angle that folks are going for, let's say in the Trump administration right now, people aren't a fan of that approach or that language or that rhetoric. But this is where that comes from, is this we will pick and privilege and choose people who are more disadvantaged. And the more advantaged you are, the more resilient you seem, the stronger you appear, the more you're like, I've overcome all these things and I'm ready and I'm raring to go and I'm capable and I'm accomplished. That's not going to sell you. What's going to sell you is is how disadvantaged you are, and all of these things that you've gone through and have never recovered from and have never gotten over. That's what's going to get you into these positions of these schools or these positions of power, etc. Now that it's reversing, and there's huge pushback against that, but that's very deeply ingrained in how these things operate. And not just race, it's in any kind of identity, again, any kind of way that you identify.
Yeah. And
Oh.
I think the other part of it is kids, especially in, grade school, high school, they want to support their friends. They want to be inclusive. I think, are there mean kids? Sure. But they're outliers, and usually something's just going on in their world. For the most part, kids are really the most open, loving, accepting group of human beings.
You don't agree, Corey?
But I mean, just how about this? Maybe let's talk about kindergartners. Just very knowing that, and we're taking advantage of that. We're telling them, okay, this is how you support your friend, or and it's the opposite. It's pouring into a distorted belief system that they were born wrong, and sorry, you're just stuck with this. And what about just allowing a child to grow into a more flexible mindset? When you put them on puberty blockers and cross-sex hormones, you're not locking them in physically only, you're mentally locking them into, I don't have a choice. I have to be this. My teacher said that I'm a really great person because of it. I can't back out. My parents helped me get to where I am today, and now what are they going to do? And that guilt doesn't need to be in a child's mind, or conflict. I don't know if guilt's the right word, but Corey totally disagreed on the kid part.
Well, yeah, that's ethnographic testimony. The parents who really believe that this stuff helps their kids, they pick up their whole families and they move.
Yeah.
And
because of the bans, you're saying, or what?
Yeah, because of the bans. So they go to states like Colorado or California or Washington, or I don't know where else. Yeah. Illinois. There we go.
Sorry. I think there's a delay on my end. I apologize.
No, so they pack up their families, and they do feel like victims, Ben. In a sense, you could make an argument for it. You could make an argument against also, but you could make an argument for it. It wouldn't be disingenuous to do so. Mm-hmm. If somehow the FDA got all of these interventions banned completely, they would just go to another country.
Mm-hmm. And they are.
Or they would find alternate provisions.
And I do think that's where I think maybe I've poured a lot of energy into education, educating parents, educating kids, educating other physicians. To me, if you're prescribing stuff, you better know everything about it. I mean, that's just irresponsible and is criminal if you're prescribing stuff and you don't have, data to support it. But for everybody else, yes, there might be outliers of parents harming their kids to somehow virtue signal. I just don't think that's the majority of the parents. I do think, as a parent, when I take my kids to the doctor, I want to be mom. I don't want them to say, well, as a doctor, what would you like to give them? I don't even want that. I know I'm sometimes illogical about, oh my gosh, how terrible what, and they're like, it's a cold, it's gonna be fine. But it's my own child. And so if an expert is saying to a parent, your child's going to kill themselves if you don't do something about this, if you don't move to another country, if you don't order hormones online from some, very sketchy, some sketchy place to get it. Or, I think these parents are absolutely doing everything that they can. And then I could see where absolutely if there's a ban in your area and no one's talking about it, and it's just like, okay, now what? Especially if they've been on puberty blockers and they need to be on something, and you can't find anyone to treat because now all the doctors are saying, oh, well, now we can't do anything. You are leaving kids and parents in a really awful situation. Because some of these kiddos are going to be dependent on exogenous hormones.
Yeah. So a point that I want to make, not just to us, because I think we know, but to anybody listening, is that these families require some support. They're getting it from the people who we disagree with strongly. I think that they have to be kept in our thoughts because they need to hear these interventions that you're trying to put your kid on are not safe for them, and they need it in a way that they can understand the argument. And hopefully books like The War on Science, hopefully that'll be one of the ways that people can learn about the ways that they've been deceived.
Mm-hmm. Yeah, well, I mean, yes, but they need to actually read the book. If they pick up New York Magazine and they read Sarah Jones's review that was published last week, Sarah Jones says that falsely that, Lisa Littman's study on detransitioners, that she had to completely retract everything that she claimed in the first one because of poor methodology. Like that was a complete false statement, that there was nothing that changed about the results, that there was more clarification required for that paper that came out later, but nothing changed about the results. But Sarah Jones specifically said that the results were changed and that it was just bunk. And so if someone picks up New York Magazine and reads about that and how ridiculous this is and how, this is all right-wing, bullshit, then that's the message they're going to get. They actually have to read the book to be able to understand that. But you do bring up a good point, Corey, is that, there is that the rhetoric can be very damaging because, if we're talking about, if there is this, oh, that parent should be criminalized, oh, that parent should be da 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 da. A lot of parents are misled. Whatever, there are parents with nefarious, and it's just like in the medical industry, there are doctors and psychiatrists who have just been completely misled, especially if we're talking about this kind of approach being taught to medical students. If they're getting out, they'll be like, I'm just doing what I was freaking told,
Right. And the textbook says to do it.
The textbook says to do it, that I'm supposed to ignore evidence-based medicine. And for this group, we're supposed to go after some kind of euphoria or
Right.
that they're in charge here. And that's my job as a physician to abide by that. But what do you guys think about the possibility of the criminalization or the legal repercussions for doctors and physicians who prescribe these things? Do you guys have an opinion on that? I'm really curious to hear what you both think.
Do you want to go first or do you want me to go first?
Go ahead.
Okay. One, if there's been criminal practice occurring, they absolutely have to be held responsible. It's one thing to say, well, we're not sure, we don't know, but this data, it has been out there in terms of harm signals. So I think the medical community is a little bit different. I think there's how do I want to put this? There's so much information out there, and if you're not even curious about it, and at the expense of child safety and child fertility, on into adulthood and adults, being able to have just an adult sexual relationship and maturity, you're denying them so many things, and the data is there that you're doing that. So it would be next to impossible for, I think, that to hold up in court for someone to say, oh, I just didn't know. I mean, yeah, they were doing really badly and I was watching the lab work just tank and they weren't functioning very well. And then we were doing surgeries. That's not going to fly. Or miscoding. Miscoding to me is fraud. I mean, it is fraud. And we're taught that. So that's something that comes up year after year, med school and residency. It doesn't matter if your patient is saying, please, whatever you do, don't code for this. It doesn't matter. It's not the patient's fault. They have every right to ask for things. They have every
You're
right
talking
to
about insurance coding.
Uh-huh.
So like
Yeah.
you're kind
So
of
if you're-
saying like pretending that something is different just so you can get the drugs that they need. Is that what you're saying?
So using things like endocrine disorder not otherwise specified, or disorders of the pituitary gland unspecified. And, I'm probably not getting the words exactly right, but that's what we're seeing a lot. That's criminal.
It is criminal. You're right.
But
It's
it is
fraud.
not criminal for the patient. The patient is not doing anything wrong,
Mhm.
even if they are asking for it. Patients can ask for all kinds of things, but
Mhm.
that doctor, you better believe they are responsible.
So it sounds like you do think that there should be legal repercussions, and it probably covers a fair bit of people who are practicing this, because you're like, unless you have these nefarious purposes, but if you're ignoring the evidence that's out there, well, that's pretty much all of them.
Right. And I think part of it too is we've tried to just say, hey guys, can we consider other things? Hey, American Psychiatric Association, can you quit endorsing this because it's harming kids? There's been, and to say that members at large do not support this, and you're telling us this is double peer reviewed, not single. They call it, it's peer reviewed when they look at the manuscript of anything they're going to publish, and it's peer reviewed on the end, when it's getting ready to get published. So they're saying it's double peer reviewed. And for anyone out there who's ever tried to publish one thing, it's a nightmare, because you want to get it right. Once it's called peer reviewed, I have to be able to trust that that has been reviewed by experts that say, yeah, this absolutely is something that you could trust, and it's not. And so, yeah, I think I feel very strongly that if you're continuing to harm kids knowingly, which ignorance is not something that holds up in court when it's a malpractice or negligence case, or a fraud case. So you don't get to say, oh, I didn't read that one. That doesn't work. But again, to me, I do not feel like, outside of, again, outliers, very, very extreme outliers, parents and patients are not responsible for that. They didn't do this. Yeah. They tried to listen to experts. Experts harmed them. And I don't care if, that's the part that I can't, it's so hard for me to hear people say, well, I did this to myself, and now I just have to, no, a doctor did that to you. And I just that grappling with, somehow now they have to live with this thing that I just, without the doctor that chose to harm you, that wouldn't have happened.
Corey, what do you think?
I asked for it.
I'm sorry. Did I?
Yeah, no, but what do you think about the possibility of criminalization, Corey, of doctors?
Well, before I answer, Ben, as a practical matter, you reminded us before we started recording, you have a hard stop time.
I know, and you're right. And so I'm looking at the time. Yeah, so we should definitely wrap up.
Do you want me to answer and then we'll wrap?
Yeah. Are you trying to get out of the answer?
I'm not.
Oh, okay, good.
It could.
No, you were just being kind, and you were like, I remembered what you said. Yes, no, I do appreciate that. But I would like to hear what your opinion is about that before we go.
Well, I think that I would put resources other places, because I would say most of the doctors who are wrapped up in this are patsies. They're just going along with what their professional societies have said. With what I know that they get continuing medical education credits for having activists come in and tell them what they're supposed to do. And this is so institutionalized that I would say most doctors are doing what they genuinely believe is the correct thing, because their opportunities to learn otherwise have, the activists have closed all the doors for critical voices to come in. There might be some exceptions, Ben, but I think that it could, I think it would be very difficult for us to understand what all the unintended consequences of starting to prosecute doctors would be.
Well, let me ask one more follow-up question then, because could a defense be, well, the APA's textbook, Gender Affirming Psychiatric Care, told me that I need to prioritize this approach over evidence-based medicine, that this is what it says is the right way to practice this. I'm just doing, so like Corey said, you're doing what you're told. But could that hold up in court? I mean, you're saying like ignorance isn't, but you're saying the evidence, but that's there. No, it wouldn't. Huh?
There's conflicting evidence. There's no strong evidentiary basis for either perspective. As Hillary Cass said, and as you quoted in your piece, Lauren, the ambiguity is going to be the shelter of the scoundrel. And any prosecutor who tries to win a conviction when all of that ambiguity exists is going to have an uphill climb. That's my take. Definitely
uphill climb. I would think maybe it's not impossible, though, the more education we can get out there. And like you said, to your point, putting resources in other places, but then also I think being able to go for the associations. No, what they do is they ignore. The Endocrine Society will ignore. The American Psychiatric Association just ignores us. Like we can't. So I think maybe that's a question that I have for a lot of people trying to better the education in this area. Certainly is, how do we provide care for these children and young adults that absolutely need support? I feel like sterilization is probably not the way to do it. And then maybe figure out a way to either turn this ship around and actually speak to this medically, or don't be a medical association. Don't call yourself the experts and don't publish the textbooks anymore if you want to be an activist. But we've got to untangle that, and maybe that way we could get some movement. But I don't know. I wish there was an easy answer, but you're right. I think it's going to be uphill no matter what.
Mm. Oh my gosh. Well, thank you so much for joining us today. I loved it. I really enjoyed it. Hopefully you did too, and our listeners as well. I'm excited. I'm looking forward to hearing the comments from the listeners too, especially about that last topic, what they think about all of that, because people do have really strong opinions about that. Anyway, thank you for joining us. Corey, Dr. Schwartz, Sarah and Jamie and Lisa will be back with us next week. Everyone have a wonderful week, and we will see you soon.
Yes, thank you guys so much for having me. Your podcast is phenomenal, so I really appreciate it so much.
Thank you very much.
It's our honor.
Thank you.
Absolutely.
Mine too.